Hello, everyone, and welcome to today's webinar. Winter is coming, Diagnostic Testing Strategies for COVID-19, Influenza, and RSV. I am Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Diasorin. To learn more, visit www.diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Matt Binnicker, Director of Clinical Virology and a Professor of Laboratory Medicine and Pathology at the Mayo Clinic. Dr. Binnicker, you may now begin your presentation.
Great. Thanks, Cassie. And thanks to Diasorin for the invitation to present, and all of you for joining me today. Apologize about the lack of video. Always some joys with technology and firewall limiting some of the things that we'd like to use, but hopefully you can hear me fine, and we'll have a good discussion on diagnostic testing strategies for COVID, flu, and RSV. So just a few disclosures before I begin. I am an advisory board member for Diasorin, as well as Mammoth Biosciences, and I'm receiving an honoraria for this presentation, as well as a few past educational webinars from Quidel and Abbott Molecular. So with that, I'd like to get started, and the objectives over the course of the next 45 minutes will be to review the variety of diagnostic testing options that we have in our toolbox to assist in the evaluation of respiratory viral infections. We'll then spend some time discussing how these tests can be used in combination and what type of diagnostic algorithms your center might be able to put in place, and how those tests can be best used, as well as the results interpreted in working up a patient with a respiratory infection. We'll then finish up with a forecast for this respiratory viral season, and I'll talk about how a variety of factors might influence the trajectory of this respiratory season, including the population's immunity, the effect and impact of viral variants, as well as the potential for viral interference, and then new vaccines that are on the horizons, as well as new viral therapies, and how those may contribute again to the trajectory and the severity of the respiratory season here in the United States. So if there was one silver lining to the COVID-19 pandemic, it was that we experienced a dramatic expansion in the testing capabilities that we have to work up respiratory infections. It was the hardest time in our lives, but in the diagnostics arena, we saw advancements in diagnostics at a pace that we've probably never seen before. And I think we're probably at a place in terms of that advancement that we may not have been able to achieve for 5 to 10 more years had the pandemic not occurred. So I'm going to review the variety of diagnostic options that we have, as well as highlight some of the advantages and limitations of those methods. So early during the pandemic, what we had at our disposal to work up cases of not only COVID, but other respiratory infections was mainly targeted molecular assays, and those were performed in a clinical laboratory. We know that these methods offer very high sensitivity and specificity. The laboratories that are performing them incorporate stringent quality control to ensure accuracy. But we know that these tests that are performed in clinical laboratories generally come at a relatively high cost. One thing that we experienced, especially in the first 6 months of the pandemic, were long turnaround times, as resulting from samples being sent to clinical labs and sometimes reference laboratories for testing. And then a challenge that we encountered was that there were concerns about these targeted molecular tests being too sensitive. In other words, we're picking up positives in patients who have had disease weeks or months earlier, and we're picking up remnant viral nucleic acid. And so that contributed to challenges about releasing individuals from isolation or quarantine. And we've known about this potential limitation with highly sensitive molecular tests for many years. Within 6 months of the pandemic beginning, there started to be antigen-based tests that became authorized for COVID-19. And over the course of the last 3.5 years, the role of antigen tests in diagnosing respiratory infections has once again been strongly debated. And I think many, including myself, have changed their opinion on the potential role of antigen tests in the workup of respiratory viral infections. We know that these tests offer very rapid results, sometimes answers in as little as 10 or 15 minutes. We have a multitude of options now for COVID-19 that can be performed in the home or in a point of care setting. And there's been quite a bit of work and study focused on the correlation of antigen results with active disease. And while that's still debated, I think that antigen tests may serve as a good indicator of when an individual is no longer shedding high amounts of virus. And we'll talk about that a little bit later on in the presentation. Of course, we know from years of experience that antigen tests may suffer from lower sensitivity, especially early during a disease course or after exposure to an infected individual. Currently, most of the at-home antigen tests are limited to COVID-19, but I anticipate that in the coming years, we may see more at-home antigen tests available for other respiratory viruses in the United States, like influenza, RSV, metapneumovirus. And then a final limitation that I would point out is that when we perform antigen testing at large volumes, testing large amounts of people, especially those who lack symptoms, there's always the potential for false positive results. And so correlation with clinical disease is always important, as well as follow-up testing by other more specific methods. Next on the scene came targeted molecular tests that can be performed either at the point of care or in the home. And this was, I think, a significant advancement that not only benefited us during the pandemic, but will also benefit us in the years to come. These molecular tests that are, again, authorized or approved for at-home or point-of-care use provide rapid results, sometimes in as little as 15 to 20 minutes. They do generally have a higher cost compared to at-home antigen tests. And in the pandemic, there was limited availability of these at-home or point-of-care molecular tests. But now there seems to be an increasing availability to purchase these tests. And I anticipate over the course of the next 3 to 5 years, we'll see a dramatic expansion in the availability and development of new at-home and point-of-care molecular tests for respiratory infections, sexually transmitted infections, and other diseases. And then finally, multiplex molecular tests. These obviously cover a range of possible etiologies, so they're very beneficial when we don't know what might be causing the infection. They generally offer very high sensitivity and specificity, but we know that they come at a higher cost, which makes diagnostic stewardship an important conversation, as well as decisions around when to use smaller multiplex panels, such as those that have 3, maybe 5 targets, or those that are larger panels with 15 to 20 targets. And we'll talk about the different patient populations where those might be most appropriate as we proceed in the presentation. So as we've seen this expansion in diagnostic testing options, one of the questions that has come up at Mayo Clinic, and I'm sure at your healthcare center as well, is how should these methods be used in isolation or in combination to diagnose respiratory viral infections? Is there an optimal strategy where we can combine these various methods to lead to an ideal diagnosis in different patient populations? And I think what I have concluded over the course of the last few years as we've had these methods available to us is that the optimal testing strategy is highly dependent on the patient. In other words, there really isn't a one-size-fits-all approach. And it also depends on what platforms and tests you have available, and also what equipment and tests you can get access to. And we know that that was a significant challenge during the pandemic, was getting access to tests. It's not so much of an issue today. So there are a number of factors that influence the type of approach that you'll use and the type of algorithm that you'll use. But again, it comes back to what type of patient is being evaluated. And based on that, we can put together, in many situations, a testing strategy that might make sense. Now, to illustrate this, I want to walk through 3 example patient cases. And I know you won't have the opportunity to submit your answers, but as I show them, I just want you to think about what you would recommend in these 3 different patient cases, and then we'll follow up and I'll discuss a proposed algorithm for the different types of patients that you might see at your healthcare center. So in this first example case, imagine a 2-year-old patient comes with their family to the emergency department. And this takes place in January, again in the United States, with a 48-hour history of lethargy, cough, fever, and a new onset of wheezing, difficulty breathing. And so with that type of a patient, young patient, respiratory illness, onset of wheezing, what test would you initially order or recommend? Would it be a COVID-19 antigen test, a COVID-19 and influenza PCR, a COVID-19, influenza, and RSV PCR, or would you recommend a multiplex respiratory panel? So in this type of patient, 2-year-old, so young individual with new onset of wheezing and other respiratory clinical presentation, there are a number of viruses that may be causing this infection, but we'd likely want to include a test for RSV, given the risk of RSV and respiratory distress in young patients. And again, we'll come back to discuss a potential algorithm in pediatric patients to drive this home. The second example case is a 22-year-old, otherwise healthy male who calls into family medicine again in January and describes a 48-hour history of cough, fever, and body aches. So this is what we would define as an influenza-like illness. In that situation, what test would you initially order or recommend? A COVID-19 antigen test, a COVID and flu PCR, an influenza and RSV PCR panel, or do we want to cast a broad net and order up a multiplex respiratory panel? So 5 years ago, I likely never would have responded that the first test you'd think about could be an antigen test. But now, having been through the pandemic and the shortages in diagnostics, and also the availability of the different tests that we talked about, one possible approach in this type of a patient, otherwise healthy, adult, no significant respiratory distress, may be to perform an upfront COVID-19 antigen test. And again, we'll come back to this. And then the third example case is a 66-year-old female. And this patient has had a bone marrow transplant, so they're immunocompromised. They present to the emergency department in January with 2-day history of cough, fever, body ache. So again, influenza-like illness, but they also have shortness of breath. And in that situation, would you order up an antigen test, COVID, flu PCR, flu RSV PCR, or a multiplex panel? And I think in this type of a situation with this patient, high-risk individual, signs of respiratory distress due to shortness of breath, here's where you might want to cast a broad net and utilize a multiplex panel, because time is of the essence, and there could be a variety of infectious diseases that may be causing disease in this patient. So think about those 3 examples again to highlight the importance of the patient in determining which testing strategy to use. And now I just want to review the way that we approached the 2022 respiratory season at Mayo Clinic. So each year, usually in August or September, we have a multidisciplinary team that gets together. There's representatives from the clinical laboratory, our infectious diseases team, primary care, and our hospital practice. And we meet and talk about our respiratory testing strategy. What viruses are going to be circulating? What tests do we have currently in the laboratory? What tests do we have in our point of care, urgent care centers? And what tests do patients have access to for at-home testing? And then we develop an algorithm that will recommend to outpatients and inpatients. And so this team developed an algorithm both for adult and pediatric patients to guide our testing approach. Now, again, I just want to emphasize that any algorithm that you might put together is going to be determined and highly dependent on the tests you have available, the equipment and platforms that you have in your clinical laboratory, and also what patients in your region have available to them for at-home or point of care testing. So let's review the algorithm that we developed in 2022 for both adult and pediatric patients. So in the adult setting, we focused on patients who, again, would call or present to an emergency department or outpatient center with a flu-like illness in the past 48 hours. If that happened and the individual was an otherwise healthy adult, we would actually recommend that they take a COVID-19 antigen test. Now, if that COVID-19 antigen test was positive, a diagnosis of COVID-19 was made, and they would be connected with their care provider or our COVID-19 care team to determine whether treatment was appropriate for them. If the COVID-19 antigen test was negative or they didn't have access to an antigen test, the question that would be asked is, does the patient have any risk factors for complications of RSV? So are they immunocompromised? Do they have cancer? Are there factors in place that might, again, place this individual at a higher risk for severe RSV disease? If the answer was no to that question, they would have a swab collected that would be sent to our laboratory for COVID-19 and influenza testing by a molecular assay. If they did have risk factors for complications of RSV, the swab would be sent to the clinical laboratory for a panel that looked for COVID-19, flu A/B, as well as RSV. What about the pediatric population? Again, this is focusing on children less than 18 who are immunocompetent. So again, patient presents with a flu-like illness in the past 48 hours. In this situation, the first question was, what's the age of the patient? Are they less than 3 years old? If the answer to that question was yes, we would get a swab, and that swab would be tested for COVID-19, flu, and RSV. If the patient was older than 3 years old, then we would calculate the Centaur score. Now, what is that? That is actually a way for us to determine a patient's risk for group A strep or strep throat. So they're, again, factored based on their age, and then they're asked whether they have tonsillar exudate or swelling, if their lymph nodes are swollen, do they have a temperature, and do they have a lack of a cough? So they get a point for each of those factors. And if they score high with their Centaur score, so greater or equal to 3 points, then those patients would get a throat swab for a strep PCR, and they would get a mid-turbinate nasal or nasopharyngeal swab for COVID, flu, and RSV testing. If their Centaur score was low, 2 points or less, those patients would have a swab collected for COVID, flu, and RSV testing. So just a few other considerations for this algorithm that we put in place in 2022, and in large part is the same that we're using in 2023, is that patients who presented to one of our urgent care locations or to our emergency department, those locations do have a point of care molecular platform where we can perform testing in the urgent care center or in the emergency department with results available in about 20 minutes for COVID, flu, and RSV. Patients who were seen at primary care or went to one of our testing sites had a swab that was collected and was sent to our central clinical laboratory. If a patient was immune compromised, and that would be either adult or pediatric, those patients were considered for testing by a respiratory multiplex panel. And again, that goes back to the example case number 3 that we talked about. And someone who is immune compromised, we may not want to take time to work them up with individual or small panel tests. We may want to cast a broad net initially based on the severity of their illness or the severity of their immune compromised condition, because time is generally of the essence to make a diagnosis and get those patients on treatment if appropriate. And then finally, an interesting aspect of 2021 and 2022 was, again, the availability of antigen tests for COVID-19. And at Mayo Clinic, we performed a study where Mayo Clinic employees who were diagnosed with COVID-19 were then tested by a rapid antigen test at days 5 through 10 after their diagnosis and prior to returning to work. And we did this because, one, we wanted to know how long do individuals stay antigen positive after they're diagnosed? And 2, given the shortages of the workforce during the heart of the pandemic, was there a way that we could use antigen testing as one component to allow some of our staff to come back to work if they didn't have symptoms? What was very interesting from this study was that almost 65% of our employees who were diagnosed with COVID-19 had a positive antigen test on day 6 following their onset of symptoms. And if you'll remember, at this point in the pandemic, the CDC was recommending that an individual diagnosed with COVID-19 isolate at home for the first 5 days, and then on days 6 through 10, they could return to normal activities as long as they were wearing a mask. And so this, again, is additional information that helped to inform some of our decision making about safely returning our healthcare workers to the hospital or outpatient settings. This is a graph from that study that again shows the probability of a positive antigen test following their initial diagnosis. So the red line is the drop in positivity in those who initially had symptoms of COVID-19. The blue line is the drop in antigen positivity in individuals who are asymptomatic at the time of diagnosis. And again, you can see that by day 6, 7, there were still greater than 50% of individuals testing positive by antigen. There were still antigen positive results in about a quarter of patients on day 8 to 9. And you can see that there is a statistically significant difference in the persistence of antigen positivity compared symptomatic individuals versus asymptomatic individuals. The symptomatic individuals tended to have persistent antigen positivity by a day or two longer than those who did not have symptoms, and that makes sense. So I hope that information is useful to you in helping to not only put together use strategies, but also interpretation strategies for when antigen testing is employed. So now I want to shift gears. We've talked about the test options that are available and the different types of applications of these tests and the algorithms that may be used and how those results should be interpreted. Now I want to shift gears and talk a bit about the outlook for this respiratory season in the United States. What can we expect? What are the possibilities? Well, one thing that virologists and public health officials and infectious disease providers typically do during our summer and fall months to get an idea of what to expect is we look to the Southern Hemisphere. And that's because in the Southern Hemisphere, in countries like Australia, South America, Africa, they are experiencing influenza season during their winter, which is corresponding to our summer. And so by looking at the flu season in Australia and other Southern Hemisphere countries, we can get an idea of not only the severity, but the types of strains that are circulating. And that's actually how the flu vaccines are formulated, is based on an educated guess based on what is happening in the Southern Hemisphere. And that's why we see years where there is a very, very good match between the strains that are circulating in the vaccine, and some years there's not as good of a match. So in the Southern Hemisphere, you can see here that this is data from the Australian CDC, and the red line is the flu season that occurred this year during our summer months. And the other lines, which are a bit fainter, represent past years dating back to 2016. And you can see that the red line corresponds with what I would call an average, maybe slightly elevated influenza season in Australia. Definitely what we would expect more in the pre-pandemic era. So when the Australian CDC typed these strains, they found that 58% of the cases were due to influenza A, with the majority of those being caused by H1N1 pandemic 2009 strain. And there were also influenza A cases caused by H3N2. Interestingly, they also found that 40% of cases were due to influenza B. Now, we typically see influenza B, but it is uncommon for both influenza A and influenza B to co-circulate. And we'll come back to that a little bit later in the presentation. The good news from the Australian experience is when they typed these strains, they found that 98% of the H1N1 pandemic 2009 isolates, 84% of the H3N2 isolates, and almost all of the influenza B isolates antigenically matched with the vaccine. So in other words, the vaccine that was being utilized was a strong match for the strains that were in circulation. In other words, the vaccine should provide good protection for those who received it. So what about here in the United States? How does that start to translate into our experience? So here's data from the end of November, and you can see that influenza cases are rising in the southern part of the United States as well as on the West Coast. And this is pretty typical that oftentimes we see influenza begin to increase first in the southern part of the country. Now, nationally, about 70% of those positive cases have been due to influenza A, again, with a similar distribution that was seen in Australia, about the majority of those being due to H1N1 pandemic 2009 strain, and a smaller fraction due to H3N2. And again, about a third of the cases have been due to influenza B, with the Victoria lineage of influenza B being the cause. Now, this is not common to see this high of influenza B at the same time as high influenza A circulation. Most years we see influenza A in the months of November through February, and then influenza B usually causes a second surge in the late winter, early spring months. And so one interesting attribute of this season has been the high rates of both influenza A and B in the early months of seasonal flu season. What about RSV? RSV has come storming back after being nearly absent in 2020. We saw a summer surge of RSV several years ago, but in 2023, we're seeing high rates of RSV, especially in the southern United States, with certain areas, especially in the state of Texas, reporting positivity rates greater than 40%. You can see the graph on the left-hand slide shows antigen positivity, again, exceeding 40%, and PCR positivity on the right-hand side of the slide with positivity rates well above 20%. I looked at our Mayo Clinic data yesterday, and we are creeping up. Whereas 2 weeks ago, we were seeing positivity rates for RSV in the single digits, we're now above 20%. So it's definitely starting to migrate to the northern states in the country. What about COVID-19? Well, COVID-19 test positivity has definitely been smoldering all summer in the United States. We have not seen positivity rates drop to zero or single digits. It has been consistently in the 5 to 10% range. Now, in contrast to influenza, where we're seeing the majority of cases in the South, rates for COVID-19 currently are highest in the central and north central states in the US. And we'll actually come back to that. I want you to remember the distribution of influenza based on the US map as well as COVID-19, because this will become important in a few slides. ED visits and hospital admissions are up about 10% for COVID-19. And we think that this is really fueled by the latest predominant variant of COVID-19, which is a descendant of the original Omicron variant. And this one that's accounting for about a third of cases is known as HV1. This variant has mutations in the spike protein that lead to increased transmissibility and immune evasion. Fortunately, it's not believed to cause more severe disease than prior variants. But again, the high rates of transmission means more people become infected and may infect a higher number of at-risk individuals that could lead to severe disease. So now that we've reviewed kind of the current situation for flu, RSV, and COVID in the United States, I want to talk about the factors that may influence the trajectory and the severity of this respiratory season. Specifically, we'll talk about population immunity, viral variants, as well as what's called viral interference, and then finally, the role of vaccines and new therapies in controlling and predicting the outcome of the respiratory season. So let's first talk about population immunity. At this point, 3.5 years after the beginning of the COVID-19 pandemic, greater than 81% of the US population has been vaccinated at some point against SARS-CoV-2. And by the third quarter of last year, the CDC estimates that 96.4% of individuals who are greater than 16 years of old have antibodies against SARS-CoV-2, and that's either from vaccination or infection. And so likely by this point in 2023, that number is approaching 100% of individuals having antibodies either from vaccination and or infection. So along with the changes that we've seen with SARS-CoV-2 as it's mutated over the last several years, and this change in population immunity, that has had an impact on viral kinetics following infection. In other words, when does the virus reach peak levels in an individual after they're infected? And that not only can influence transmission, but also diagnostic testing. So early in the pandemic, we knew that the peak viral load generally corresponded with an individual's onset of symptoms. So if a patient presented with a respiratory illness, that was typically when you wanted to test and when you had the highest chance of detecting an infection. But now we're 3+ years into the pandemic. We have this change in population immunity. And so how has that changed the kinetics? And there was a recent study that looked at this. And this was performed about 2.5 years after the pandemic. They looked at 348 patients who were newly diagnosed with COVID-19. And each of the patients who were enrolled had a history of vaccination and or prior infection with SARS-CoV-2. And what did they find? This study demonstrated that the lowest PCR cycle threshold values were achieved 3 days after the onset of symptoms. So that means the highest amount of virus leading to a low PCR CT value wasn't occurring until a patient was, on average, 3 days into their illness. And then they looked at antigen concentrations and estimated that the highest antigen concentration, which we usually think corresponds with the highest amount of infectious virus, was occurring on average on the 4th day following the onset of symptoms. So this is really important from a transmission perspective and also a diagnostic testing perspective, because when a patient shows up on day 1 with symptoms, their PCR or antigen test may be negative. And so we've now been recommending that we can't use a negative antigen or a negative PCR early and after symptom onset to rule out COVID-19. That if symptoms persist, getting a follow-up test several days later is typically recommended. What about viral variants and the potential for viral interference? So first on variants, I talked about HV1, and also there's another variant called EG5, which we called Eris. Those are the 2 predominant strains in the United States. These are both descendants of Omicron. They have mutations in the spike protein that lead to increased transmission and immune evasion. So they will likely continue to fuel the increase in cases, and there's a new strain that is also increasing in prevalence and over the course of the next month or two will likely replace EG5 and potentially HV1. I want to spend just a few minutes talking about viral interference. So these are the two graphs that I showed earlier in the presentation. The one on the left is influenza. The red states are where there's higher rates of flu. The graph on the right is COVID-19, and the area shaded in yellow and orange is where there are higher rates of COVID-19. So you'll see that there's an obvious separation of where there's high rates of COVID and where there's high rates of influenza. And is viral interference playing into that distribution? So first of all, let's talk about what viral interference is. We'll all remember that in 2020, we all experienced a near absence of respiratory infections other than COVID. So there was almost zero influenza, RSV, and other respiratory illnesses in the US. We likely attributed this to masking, the halt in global travel, social distancing, which I think were all important factors. But was there a role of what's called viral interference? So the possible mechanism of viral interference is that when an individual has infection with one virus like SARS-CoV-2, that can induce an innate immune response like interferon that inhibits infection with a second virus, potentially influenza. And there have been multiple studies that have shown that this can occur both in mouse models and in humans with viruses like human metapneumovirus, RSV, and influenza. And so I think that there could be something here, whereas an individual infected with SARS-CoV-2 may be less likely to also be infected with flu. Now, of course, we have seen patients who are co-infected, so it doesn't explain everything, but I have not observed the rate of co-infections that I anticipated 3 years ago. Vaccines and therapies. This has been a banner year for RSV prevention and treatment. We now have multiple FDA-approved vaccines and monoclonal antibody therapies for RSV, and these are now recommended for individuals older than 60 years old, pregnant women, infants less than 8 months old, and children less than 24 months old who are at high risk of severe RSV disease. I'm excited about this and anticipate that in the coming years, as we have greater access to these therapies, but patients also take these vaccines and therapies, that we'll begin to see a reduction in the incidence of RSV disease. With regards to COVID-19 vaccines, if you've been vaccinated prior, great. If you did not receive the updated COVID vaccine that targeted the XBB.1.5 or Omicron strain, I would recommend that you consider that. There are enough changes in the currently circulating strains where prior vaccination a year ago, 2 years ago, is likely not going to protect you from infection with these new variants. The good news is that updated COVID-19 vaccine does, based on early studies, show strong protection against severe disease caused by the strains that are most commonly circulating today. Again, EG5 and HV1. I want to finish up with influenza vaccines and therapies, so the future advancements. Of course, the holy grail is a universal flu vaccine where we don't have to have an annual vaccine booster. And there are studies underway at the NIH and NIAID to look at the development of a universal flu vaccine. Also, combination COVID and flu vaccines. One of the limitations to people getting vaccinated is the hesitancy to receive multiple vaccines. And if we can administer both in one, I think it will increase the uptake. Both Moderna and other vaccine manufacturers are looking at this. Moderna is looking at an mRNA combined vaccine that is in phase 3 trials, and their phase 1 and 2 trials showed that this combo vaccine elicited antibody titers that were at similar levels to when those vaccines were delivered individually. What do we have to look forward to in the future in terms of diagnostics? I think we'll see a dramatic advancement in point of care and at-home applications. Flu, RSV, these are all in development. I anticipate over the next 3 to 5 years, these will become common. Some gaps that will need to be addressed. We're going to have to ensure that they're performing at a sensitivity near or close to lab-based tests. We've got to be able to integrate these results with individuals' healthcare providers so that treatment and management decisions can be made. We've also got to integrate these at-home or point of care results with the public health infrastructure for disease tracking. Right now, we're flying a bit blind because of the high rate of at-home antigen tests that are not closely integrated with public health. And then artificial intelligence is of course a buzzword right now. And is artificial intelligence likely to play a role in respiratory viral infection diagnosis in the future? I think it probably will be. There's already been several studies looking at the application of AI. Here's one from 2022 that looked at AI to diagnose influenza infection. And what they did was they used cell phone pictures of patient's throat, so pharyngeal images, as well as clinical information and vaccine history. So they did a training set of roughly 7,800 patients. So they took pictures of individuals who did not have disease. They took pictures of individuals who did have influenza-like illness, and they trained their data set to be able to discriminate between the two. And then they did a testing set of over 650 patients where they inputted age, sex, heart rate, hours from symptom onset, their max temperature, their vaccine status, and the results were pretty promising. The area under the curve was 90%. The sensitivity was above 75%, which isn't great, but it's getting there. And the specificity was almost 90%. So I think this is a strong proof of principle study that shows that AI and even using our cell phone technology may perform an initial screen for respiratory infections in the future and determine who might benefit from testing by PCR or antigen tests. So to summarize, we now have multiple methods available to us, targeted molecular antigen multiplex tests to diagnose these infections. I'm surprised to say that antigen tests may be useful as an initial screen for symptomatic COVID-19, but if you get a negative result, you really need to follow up with additional testing, especially given the changes in viral kinetics that we're seeing. Small multiplex panels are very useful due to the overlap in clinical symptoms. We can't discriminate between influenza and COVID-19 and sometimes RSV. The very large multiplex panels may be very appropriate in immune-compromised individuals or those with severe disease. And as I pointed out early in the presentation, the best strategy is highly patient-dependent. This respiratory season is very likely to be similar to those that occurred pre-pandemic. We're already starting to see flu and RSV surging in the southern parts of the US, and that is beginning to migrate north. And then population immunity has changed SARS-CoV-2 viral kinetics, and the potential role of viral interference may limit high rates of flu and COVID within a region. I believe that the future of diagnostics for respiratory infections is going to move closer and closer to the patient. So over the course of the next 3 to 5 years, we'll likely see more at-home, point of care, molecular diagnostics that are closely integrated with our healthcare and public health systems. Here are a few references that you can seek out to get additional information. And I want to thank Dia Soren again for the invitation and LabRoots for hosting this presentation. And I'll look forward to answering any questions that you might have.
Thank you, Dr. Binnicker, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left corner of your screen, and we'll answer as many questions as we have time for. Let's go ahead and get started. Our first question asks, is the relatively high percentage of flu B cases, about 40% in southern hemispheres and about 30% in northern hemisphere so far, surprising or expected?
Yeah, I think it's a bit surprising. Again, pre-pandemic, we would historically see influenza A between the months of November and February, and then always expect to see influenza B come up in late February and maybe persist through March. So to see these high rates of influenza A and B co-circulating is a bit surprising to me.
Thank you. Our next question that we have here says the Australian data that shows that 58% of influenza-like illness cases are due to flu A. Do you know the breakdown between H1N1 and H3N2? And is there a reason for one of those subtypes to be more prevalent than another? Competitive advantage in the season?
Yeah, very good question. So both in Australia and our early experience in the US have shown that H1N1, so that pandemic 2009 strain, is accounting for the majority of the typed influenza cases. Probably about tenfold more influenza A cases are due to H1N1 compared to H3N2. As to the reason why, likely is that H1N1 strain has some sort of competitive advantage in terms of higher rates of transmission and maybe population immunity that is lower or not as protective from infection as H3N2.
Great, thank you. Our next question here that we have says, have the at-home COVID tests been keeping up with all the new variants?
Yeah, so the good news about the antigen tests is that they typically target a different region of the virus, a different protein than the spike protein, which is where we've seen the majority of the mutations in the virus. So the antigen tests are believed to be able to continue to detect these new variants that have been accumulating mutations in that spike protein because, again, the antigen tests are looking for a different protein.
Wonderful. All right, our next question says, does the timing for getting results mean that respiratory or airborne disease precautions should be in place in more places more often?
Yeah, so the timing of getting results for tests that are going to a clinical laboratory where those results may be delayed by hours or even a day, I think it's a good idea to always counsel patients on taking appropriate precautions before they get their results back. In other words, don't return to work, don't return to school, don't get out in public until you have your result back. And also, even if you get a negative result back for COVID or flu or RSV or combination, if you have symptoms, you may be infected with another respiratory virus. We didn't talk a lot about human metapneumovirus or rhinoviruses. And so my counsel to patients and physicians that I talk to is, if you're sick, stay home. And if you have to get out and you have any respiratory symptoms, wear a mask. I think those are just good common sense steps that we can take to keep others safe in our communities.
Absolutely. Wonderful. We have time for a couple more questions here. So if you have any questions you'd like to ask our speaker, go ahead and submit them now. Our next question here says, the respiratory seasons are opposite in southern and northern hemispheres and are always in the winter. Does that have anything to do with the actual weather at different times of year?
Yes, it's actually one of my favorite topics in infectious disease is the seasonality of disease. And it turns out that there are many factors that contribute to the seasonality of respiratory viruses. Many that you might talk to would say, oh, it's the cold outside, people are indoors more. That may be one factor, but it's actually a number of things that all play into surges in viruses like flu and COVID and RSV in the winter months, the colder months. During the cooler months, our immunity is not as well functioning as it is at other times of the year. In the winter months, the humidity levels are much lower, and we know that higher humidity leads to lower levels of transmission of respiratory viruses because the droplets in the air are larger. And so when someone coughs or sneezes, those droplets that contain viruses fall to the floor or ground faster. So low humidity equals small aerosols that can spread and persist in the air for longer periods of time. So it's really multifaceted why we see this surge in viruses like flu and COVID and RSV in the winter months.
Interesting. Great, thank you. Our next question that we have here says, you mentioned multiplex for high-risk populations. Historically, there are reimbursement challenges in the outpatient setting. Do you see this in your urgent care centers?
Yeah, reimbursement for multiplex panels is a challenge for our center, and I know for probably everyone who's dialing in today. Currently, the reimbursement is for either very select groups, and most patients is only being reimbursed for panels that test for 3 to 5 targets. So I would just urge everyone who's involved in using these tests to think about studies that can demonstrate how these tests are used and how they can be appropriately used and interpreted in both immunocompromised and immunocompetent patients, because that data that we generate is going to help influence the reimbursement strategies in the future.
Great, thank you. And we have time for just one more question today. That question says, are there any other emerging respiratory viruses that we need to be worried about?
So fortunately, knock on wood, there doesn't seem to be any novel viruses that are in the news right now. There are, of course, always COVID variants coming up, and I anticipate that we'll see a number of variants rise in the coming weeks and months that will lead to higher rates of transmission. One thing I did want to mention is that in China, they're seeing a really high rate of respiratory disease in young children. And there was some concern that this might represent a new pathogen or a new virus. And it turns out that these cases in China and all these children are due to RSV, influenza, COVID, and then many of these individuals are also infected with a bacteria called Mycoplasma pneumoniae. In China, they had very strict lockdowns throughout the last 2 to 3 years. And as children are beginning to return to schools and interact with others, it's just expected for these infectious diseases to pass from individuals, especially children. So I think that's what's accounting for the explosion in respiratory infections. We've also seen here in the United States, I believe in the state of Ohio, a condition which was originally called white lung because on chest x-ray, patients were showing just a whiteout of their lungs. And those have also, it's believed to be due to a higher rate of mycoplasma infections that can lead to a community-acquired pneumonia. So I just point those out, those examples out as some things to keep an eye on. We talk a lot about COVID, flu, and RSV, but there are many other causes of respiratory infection to be aware of.
Thank you again, Dr. Binnicker, for your time today. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions that we did not have time for today, and any of those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.